ECMO and intra-aortic balloon pump. So the patient with respiratory failure or cardiogenic shock refractory to medical management, temporary mechanical support can be utilized as a bridge to recovery and bridge to decision making, bridge to destination therapy as transplant or VAD. Options available in the cardiothoracic surgeons include the intra-aortic balloon pump, extracorporeal membrane oxygenation, and temporary VADs. Durable VADs can also be used as durable mechanical support. So the outcome is to anticipate and avoid the complications, and if they happen, then fix them in a timely fashion. The intra-aortic balloon pumps are most commonly used circulatory assist devices in cardiogenic shock. This device consists of two fundamental parts: a double lumen 25 to 50 ml balloon catheter attached to a console, and balloon is inflated with the helium gas, low density and easy absorption into the blood. In the case of balloon rupture, balloon size is determined based on the patient's height. Inserted percutaneously by the femoral artery, the balloon is passed retrograde up to the aorta, and the balloon's distal tip should be just distal to the left subclavian positioning of the IABP. Too distally in the patient's aorta will drastically to reduce the clinical effects, which can result in the malperfusion of the abdominal aortic branches. Fluoroscopic or echocardiographic guidance can be utilized to ensure the correct positioning. Once positioned, the inflation-deflation of the balloon is triggered via ECG or the arterial pressure tracing. When the ECG is utilized for timing the middle of the T wave, or the ECG triggers inflation and the peak of R wave triggers and deflation. When the arterial pressure tracing is utilized for timing, inflation occurs in the dicrotic notch onset of diastole, and deflation occurs in the end diastole just prior to systole. Inflation results in augmentation of the aortic root pressure and thereby improving the coronary perfusion pressure and the cardiac output. The deflation just prior to systole decreases the afterload, which in turn reduces the myocardial work and augmenting the systolic blood pressure. The balloon can be set to assist every beat, 1:1 augmentation to the heartbeat, or less frequently as indicated in the patient's hemodynamic. Correctly recognizing inappropriately timed IABP inflation deflation is critical. The aortic counterpulsation, a review of the hemodynamic effects and indication of the use catheter. So the manual adjustment to the timing must be made if aberrant inflation or deflation is present. Relative contraindication of utilization of IABP is significant aortic or iliofemoral atherosclerotic disease, rendering the insertion of the balloon impossible at the risk of the iatrogenic embolic phenomena, as well as tachyarrhythmias, which do not allow sufficient time for balloon inflation and deflation. Absolute contraindication include the aortic insufficiency, aortic aneurysm, and the presence of the aortic stents and the aortic dissection. Weaning from the IABP is accomplished by gradually reducing the ratio of the augmentation over 12 hours, and note that the balloon should never be turned completely off while within the patient unless the patient is systematically anticoagulated, and even when they should be avoided if at all possible due to the risk of thrombus formation. So death in ECMO is a cardiorespiratory arrest. ECMO support creates an artificial circulation to the transport of oxygen and blood. It's an established modality supporting the patient with respiratory failure despite the optimal mechanical support, as well as the patient with cardiogenic shock. A patient's deoxygenated blood drained from the vein, and the assistance of the pump passed through the gas exchanger, oxygen and CO2 exchanger, and then returned either to the vein or in the veno-venous ECMO or the artery in VA ECMO. This is ECMO circuit. The types of ECMO. This is parallel VA and VS ECMO, and the differences between VA ECMO and VV ECMO is described in this chart. So the VV ECMO, venous ECMO is indicated in general for those patients with respiratory failure whose oxygenation and or ventilation does not respond to optimized medical ventilation, as well as adjuncts including the proning and the chemical paralysis. The extracorporeal life support guidelines include hypoxic circulatory failure, CO2 retention, severe air leak, need for intubation, immediate respiratory collapse. Contraindications include mechanical ventilation for more than 7 days, immunosuppression, CNS hemorrhage, irreversible comorbidity, and advanced age. The decision to initiate ECMO in the presence of one or more of these relative contraindications should be considered in individualized fashion. A respiratory ECMO survival prediction score can be calculated to predict the likelihood of survival to discharge for a patient being considered for the ECMO in setting of the acute respiratory failure. The components of this score include the age, immunosuppressed status, diagnosis, and the clinical characteristics related to the severity of the patient's cardiopulmonary bypass collapse prior to the initiating ECMO. Patients are assigning class 1 to class 5 with good to poor survival. The several access configuration exists for the drainage and reinfusion catheter placement, and these advantages are drawbacks to each other. Consideration includes surgeons' familiarity to the access technique, flow, relative risk, and recirculation of oxygenation and blood back to the ECMO circuit. The venous drainage cannula and sizing is critical. The shortest and the widest range cannula should be placed to maximize the drainage and the flow. Vessel diameter can be measured from the ultrasound. Femoral drainage cannulas should be positioned with either distal tip into the intrahepatic IVC return cannula or should terminate in the cavo-arterial junction. Ideally, 8 centimeters of distance should be present between the drainage and reinfusion of the cannulas to avoid the recannulation. The patient should be anticoagulated just prior to the cannulation with 50 to 100 micro kg of heparin and maintained on therapeutic anticoagulation. ACT, PTT or anti-10A levels can be utilized to monitor the anticoagulation. In the presence of the contraindications, the anticoagulations to the trauma or development of bleeding anticoagulation can be held with the vigilance of the thrombotic phenomena. In general, while VV ECMO, the following oxygen saturation should be maintained: SpO2 80 to 85, PaO2 50 to 55, SvO2 65. Blood in the reinfusion cannula should be maximally oxygenated. However, low system PaO2 and oxygen saturation may be tolerated. Delivery is sufficient for the N organ. Poor oxygenation can be addressed by the following maneuvers: increase pump flow, increase oxygen carrying capacity, address recirculation, and address the causes of increased oxygen consumption and replace the oxygenator. The poor ventilation can be assessed by increasing the sweep, increasing the minute ventilation. While on VV ECMO, 3 pressures are monitored: the pump pressure, pre-oxygenation and post-oxygenation pressure. Pre-pump pressure should remain less than negative 100 and pre-oxygenation pressure is not held as an absolute value but rather should be trended. Increasing pre-oxygenated pressure is a sign of oxygenated thrombosis, and post-oxygenated pressure should be less than 300. Typical flows on the VV ECMO should be 50 to 80, and low pump flow with the venous cannula chattering indicates that the flow to the blood in the ECMO circuit is inadequate, and this can be addressed by repositioning of the cannula, lowering of the RPM, or increasing the circuit volume. The low pump flow without the venous cannula chattering suggests an issue with the pump itself or afterload. The thrombosis within the circuit or kinking of the cannula should be addressed, and the presence of the abdominal compartment syndrome or tension pneumothorax should be ruled out. While on VV ECMO, lung protective ventilation testing is critical to promote the recovery of the natal lung function. Plasma-free hemoglobin and lactate dehydrogenase should be monitored daily as a marker of hemolysis. The clinical significance of hemolysis is diagnosed when the plasma-free hemoglobin is more than 50 millimeters of mercury. The thrombosis within the circuit should be sought if the clinical significant hemolysis is present. Post-oxygenation pressure can be reduced as well. Decannulation may be considered when the patient demonstrates improved oxygenation with a stable ECMO setting. The chest X-ray may also demonstrate the progressive improvement, meaning entails the gradual decreasing of the sweep gas ECMO FiO2 and thereby returning the burden of oxygenation and ventilation to the patient's lung. Flows are not altered during the weaning from VV ECMO. A capping trial with sweep ECMO FiO2 turned off should be undertaken prior to decannulation. Lastly, a Silly test can be done. This involves increasing the fraction of the inspired oxygen, and if the patient's SpO2 rapidly increases to 100%, separation from ECMO has a good likelihood of success. Outcome: there are two important trials, Caesar trials and EOLA trial, and they show good results. The VA ECMO or venous arterial ECMO is indicated for cardiogenic shock, post-cardiotony shock, and the patient with acute or chronic cardiomyopathy as a bridge therapy. Hypoxia should be addressed prior to making the decisions to initiate the VA or VV ECMO, as oftentimes this will result in correlation of the patient's hypotension. Patients who are both hypoxic and hypotensive deserve the additional consideration, specifically hypoxic patients with a mild hypertension and a low dose vasopressor requirement in setting of the previously normal heart function will likely require the VV rather than VA ECMO. Correction of the hypoxia with VV ECMO is often resolved with hypotension as well. The contraindications are non-recoverable cardiac injury and aortic insufficiency, contraindication to anticoagulation, advanced age, and chronic and organ failure. The VA ECMO can be established centrally via ascending aorta and the right atrial venous cannula or periphery. The peripheral access can be established by bifemoral, IJ axillary or IJ common carotid cannulation. If the femoral access is utilized now for inflow cannulas, a distal limb perfusion cannula can be placed in the superficial femoral artery. The management: as with VV ECMO, the patient is heparinized prior to cannulation and maintained on therapeutic anticoagulation during the ECMO run. However, in contrast to VV ECMO, due to the elevated risk of systemic embolization during the VA ECMO, there should be a very high threshold to stop anticoagulation. Once a VA ECMO or the cardiac index is 2.2 liters per minute per meter square is targeted, the vasoactive agents are weaned as able. The lactic acid and UAP are treated as a marker of end organ perfusion, and serial echocardiography is utilized to monitor the native cardiac recovery. A number of complications should be anticipated while a VA ECMO. These complications and potential maneuvers to address them include the LV distension, north-south syndrome, limb ischemia. Outcomes according to the ELSO data registry are the outcome is 41%. The temporary ventricular assist devices are additional options and in the temporary mechanical support. As with VA ECMO, these devices are indicated for cardiogenic shock. The impeller comes in several configurations for the left heart support, including the 2.5 CP and 5.0. The right heart configuration is also available for impeller. Impeller 2.5 is a CP system, is inserted percutaneously via the femoral artery, and 9 catheter is advanced retrograde fashion up to cross the aortic valve, and the device tip sits in the LV where the blood is extracted and then returned to the patient through the outflow orifice in the patient's ascending aorta. The pump itself is internal and is microaxial, and 2.5 system achieves follow up to 2.5 liters per minute, and CP achieves a follow up to 4.3 liters per minute. A 5-0 system is inserted by a surgical cut down into the femoral artery or the axillary artery by a 9-French catheter. It is positioned across the aortic valve in the manner similar to that of the 2.5 as the name implies. This pump achieves a flow of 5.0 liters per minute, and these devices sit across the aortic valve, and there are contraindications in setting of the moderate or greater AS or AI. The presence of the LV thrombus is also contraindication for severe peripheral vascular disease, and these devices require systemic anticoagulation. Impella is approved for 6 hours of use or less, but the clinical practice typically used on a time scale from days to weeks. The tandem heart is a percutaneous valve system which extracts blood from the left atrium and returns to the femoral artery, and this is accomplished via the 21F transseptal inflow cannula, centrifugal pump, and 17F femoral artery catheter. Pump can deliver up to 4 liters flow. Contraindication to tandem heart included VSD and factors prohibiting the systemic anticoagulation, aortic insufficiency, and several peripheral assist devices. Centrimac by the Abbott is a surgically implanted extracorporeal centrifugal pump which is able to provide 10 liters of flow for RV support, and system utilizes 22 FR flow catheter placed on PA, inflow cannula, and RA for LV support, and the outflow catheter is placed on ascending aorta, and inflow established in either LV or LA. Used by Centrimac is contraindicated and systemic anticoagulation is not possible. Thank you. Hope you have enjoyed this discussion.